Good evening. Good evening, everyone. My name is Ron Derby, Editor-in-Chief of the Mail and Guardian. Welcome to our talk about yet another phase in this global war against COVID-19 with South Africa, once again, at the center of this war, of the war front because of our, exceptional scientific community. In the world, exhausted from almost 2 years now of COVID-19, over the past week, we got news of yet another worrying turn in the pandemic. Omicron is yet another variant of COVID-19, and the first phase was reported in Botswana on November the 11th, I think, a couple of weeks ago. Now, the most dangerous variants to date have been Alpha, that was first reported in the UK, and the Delta variant that was first reported in India. It's still early days yet, but scientists have warned that this variant, the fifth one, since last year, could be more contagious and could spread much faster. Gauteng is, for the moment, is the epicenter of a new variant. So tonight, the Mail and Guardian takes pleasure in inviting Shabir Madhi, who is a professor of vaccinology and a director of the South African Medical Research Council and a virologist at Wits University. But before we start, I just want to let participants know that I'll put questions to the professor from the audience as well. So good evening, Professor, and thanks very much for joining us.
Good evening. Thanks for having me, Ron. And just a little correction, a vaccinologist, not the virologist.
Oh, sorry. Apologies. Nerves always get me at these moments. As I said in my intro, we've had about 5 variants of COVID-19 since March last year, Alpha and Delta, of course, being the deadliest. While the science is still, developing and rather early when it comes to the kind we're dealing with, just what is particularly worrying about this variant?
So the major concerns of this variant currently are more theoretical concerns, which needs to be corroborated by studies in the laboratory, as well as clinical follow-up of these individuals. So what has happened now is that this particular variant has got much more mutations than what was evident in either the Alpha, Beta, Delta, Gamma variants that have evolved in the past. And of importance, many of these mutations are involving what is known as a spike protein, which we all know to be the critical element of the virus to be able to gain entry into the human cells. And those mutations of the spike proteins are at sites on the spike protein against which the antibody activity is usually targeted to be able to neutralize the virus. Now, so the one concern that exists is these multiple mutations of the spike protein, and theoretically, based on where those mutations are, we expect antibody that's targeted against the virus, either antibody that's induced through natural infection or through vaccines, which are mainly using a spike protein as its target, that those antibodies will have less activity against this particular variant. To what extent it will differ compared to how poorly those antibodies perform against a beta variant, that still remains unknown. And that's the test that will become available in the near future. But in addition to the spike protein, there's also a few mutations that are taking place in another part of the virus known as the N protein. Now, that is especially important in a context that the N protein is currently not targeted by all of the vaccines. There are new vaccines constructs currently in development that also target the N protein. But the reason why that's also important is that people that are naturally infected, natural infection in fact induces really good protection against severe disease and death. And part of that immune response to natural infection includes not only antibody, but also what we call T-cell immunity against the N protein. Now, I'm introducing another concept. I've introduced a concept of antibody activity and T-cell immunity. And this is when we need to pause in terms of making too many extrapolations, because there's been a large number of mutations that this variant is necessarily going to be more virulent, cause more severe disease, or will more easily transmit. Those are theoretical concerns, but the T-cell immunity, and a good example of this is what was experienced with the AstraZeneca vaccine in South Africa. So with a beta variant as an example, the AstraZeneca vaccine, the antibody that was being induced had very little antibody activity against the beta variant. But at the same time, the T-cell immunity that was induced by the AstraZeneca vaccine had good activity against the beta variant, because most of the mutations didn't affect the T-cell responses. So what were the clinical implications of that? The AstraZeneca, on the one hand, in South Africa, didn't protect against infection and mild COVID due to the beta variant. But on the other hand, in a study from Canada, as an example, it showed that even a single dose of the AstraZeneca vaccine reduced the risk of severe disease due to the beta or the gamma variant by 80%. And the reason for that sort of discrepancy is one of T cell immunity being less affected and also being much more diverse in terms of its targets compared to this antibody activity against the virus that's induced by vaccines as well as past infections. Now, with the Omicron variant, it's got more mutations than the beta variant, including a few mutations of the N protein, but all of this are theoretical concerns at the moment, and it's really the laboratory work that will take place in the next week or two, as well as ongoing observations clinically in terms of seeing how many of these individuals end up in hospital and if there's any change in patterns of which age groups are ending up in hospital that will eventually determine the clinical relevance of the theoretical concerns of the mutations that have been identified.
Okay, so this data will come out over the next couple of weeks. We'll get more increased data regarding this variant.
Correct. So in the next week or two, we should get data from the laboratory. But whether the variant results in massive numbers of additional hospitalizations and whether breakthrough infections, so we do anticipate there will be breakthrough infections from vaccines in people that are vaccinated. But that's not an important question because that also exists with the Delta variant as an example, where breakthrough infections are fairly common. The important thing is whether those breakthrough infections, especially in high-risk individuals, goes on to develop into severe disease. And that is a critical question, as well as whether reinfections in people that have been previously infected goes on to develop into severe disease. And that clinical information, epidemiological data, will also become available in the next 2 to 3 weeks, because usually the hospitalization and death lags behind by about 2 to 3 weeks compared with the infections that are transpiring in the community.
Mm-hmm. Now we've read reports about this variant being has more mutation than any others that we've seen so far. What stimulates these mutations?
So these mutations are random sort of reading errors of the genome of the virus as the virus is replicating. And right now there's been thousands of mutations that have occurred in the virus, most of which has gone relatively unnoticed. The only time when we really sort of identify these mutations is when we experience what is currently being experienced, and that is sort of a slight change in epidemiology of COVID-19. As an example, what occurred in South Africa with the Omicron variant is that there was an outbreak that was occurring in Tshwane, in an area in Tshwane around a university. The NICD went out to investigate that outbreak, as part of which they did sampling, and they also did sequencing of the virus. And then there were a few other sort of things that were being observed in the laboratory, which was somewhat unusual about what was being diagnosed as being positive in the lab. And it's upon acting on that sort of information and doing that sort of investigation that this variant came to the fore. So it was sort of unmasking of something that has already probably existed in the community, not for the past week or two. This variant, in all likelihood, has been circulating possibly 3, 4, 5 weeks already. So it's difficult to tell exactly at which time point. It was identified a week ago, but difficult to pinpoint exactly when. And in fact, also difficult to pinpoint exactly where it would evolve. It doesn't mean that the variant was first identified in South Africa and Botswana, that is where the variant actually evolved. As you know, there's a case reported in Belgium of an individual that traveled to Egypt with no direct or indirect contact with someone from Southern Africa who tested positive for the same variant. So the reason South Africa is able to identify this at a relatively early stage, not necessarily in real time, is simply because of the sort of sequencing facilities that have been set up and the very sort of systematic sampling of the virus that's been ongoing almost from the start of the pandemic. So that puts us in an advantageous position for early detection of these sort of variants compared to most other countries in Southern Africa and, in fact, most other countries across the globe.
It almost puts us in firing line every time there's a new discovery of a variant, right?
Well, unfortunately, that's a consequence of knee-jerk reactions on the part of government, who seems to be somewhat oblivious to the experience over the past 2 years. So if governments decide on action based on political appeasing the populace and on political grounds rather than based on scientific merit, then yes, it's to our disadvantage eventually to go public with this. But it's also our responsibility at the same time to be public about this information, because it doesn't have only relevance to South Africa, it's got global relevance. And we can't have a situation that we don't announce this variant, allow for it just to continue dispersing, knowing that it exists, and not give scientists the sort of head start to start work around this variant, including the possibility of adapting vaccines to be more specifically targeted to this variant. But certainly when governments react the way they did in this particular instance and shutting down the whole of Southern Africa, imposing a travel ban, that is particularly unhelpful at multiple levels.
Yeah, it's rather panic leadership in a sense. Kind of, even though we've had this for some 2 years, lessons are hard to learn. No?
Well, lessons are easy to learn. It's whether you want to be blind to the lessons or whether you want to take it to heart. So the science is there. The science clearly shows that unless a country is closing its borders to the entire world, just closing your borders to a handful of countries will have absolutely no impact. It might delay the importation of the variant by 1 or 2 weeks. But in a broader scheme of things, it will have a minimal impact on whether the virus will arrive in your country or not, unless you do what New Zealand, as an example, did, which has been shutting itself off from the world for almost 2 years now. And what Israel is trying to do, thinking that they're still at an early stage of detection of the variant, and now closing their borders to the rest of the world. Just selecting out a few countries which might be reporting the variant and believing that the variant is not going to be imported into your country. Unfortunately, that's a pipe dream. And that has been experienced with Alpha, Beta, and Delta. And this is not going to be any different for Omicron.
Now, Omicron comes as large parts of the developed world successfully have launched their vaccination programs from the end of last year, the early parts of this year. Less so for the developing world, right? In particular, our continent. Now, here at home, just under a quarter of the population, I think, has been fully vaccinated. It's not where we wanted to be at this stage, but just how much of a defense do you think is the vaccine against the current variants and others that may emerge?
Yeah, so I hate to first start off by saying that we haven't fully vaccinated a quarter of our population. We need to be clear in South Africa that the single dose of the J&J vaccine is not complete vaccination. You need 2 doses of the J&J vaccine to optimize protection against severe disease. So currently it's only about 9 million people of a population of 60 million that have received at least 2 doses of the vaccine. So that is sitting more closer to 15% rather than 25% that have got, now I wouldn't even call it adequate, but that have got reasonable protection against severe COVID-19. So where we are compared to the rest of the world, we're obviously lagging behind. Vaccine coverage has been extremely disappointing. By now, we should have vaccinated 90% of the population above the age of 35. And in fact, we haven't even got to 60% of people above the age of 50, which is really the priority group because they contribute to 85 to 90% of hospitalization and death in South Africa during the course of the first 3 waves. And we're needing their coverage to be at least 90%. And that would put us in a relatively stable footing when we do experience a resurgence, which is currently underway. And it's also about how wisely we use vaccines. It's not just about a number of people that are vaccinated. As I tried to allude to, it's about who's been vaccinated optimally and being targeted in our approach to achieve the main goal of vaccination. The main goal of vaccination right now is not to prevent infections. That is a good to have, important, but a good to have. The main goal of vaccination is to minimize the chances of people ending up in hospital and dying. And again, to emphasize, that can be achieved by having more than 90% of people vaccinated that are above the age of 50, as opposed to having a quarter of the entire population vaccinated, which will be more number of doses administered, but would be much less efficient use of the vaccine. So we are unfortunately lagging behind, and there's multiple reasons for that. Obviously, there's vaccine hesitancy, which is unfortunately fueled by misinformation. But the other big factor, unfortunately, in South Africa is not even so much about hesitancy. I believe it's one of apathy. So we've got security of vaccine supply, and I don't think the populace just appreciates the importance of everyone eventually getting vaccinated, but to prioritize those groups that I first mentioned. But eventually, everyone really needs to get vaccinated. And it's not because vaccines will completely abrogate your susceptibility to being infected with the virus, but even a modest impact of vaccines on infection, as well as a modest impact on vaccines making someone less able to transmit the virus. Those things to put together in the long term is where we need to be to minimize the amount of virus that transmits in the country and to maximize the protection of people from being hospitalized and dying of COVID.
Now, with regards to those South Africans that have been fully vaccinated, can you give us an essence of just how protected, how safe are we, those that have been fully vaccinated with regards to this current variant that we're talking about? And
right. So for current variant, unfortunately, we don't know yet. And we'll probably be able to get that information again within the space of the next 3 to 4 weeks. Those studies are underway to understand the effectiveness of the vaccines against Omicron, and especially how well it protects against severe disease. So I fully expect that we're going to see substantial number of breakthrough infections in people that receive 2 doses of the Pfizer vaccine as well as a single dose of the J&J vaccine. We are going to experience a fair amount of breakthrough infections in vaccinated individuals, probably but less than in unvaccinated individuals to start off with. But the difference is that this time around in vaccinated individuals, those breakthrough infections are less likely to result in severe disease, irrespective of the age of the person. So vaccination, yes, it will result, there will be breakthrough infections because of the mutations that are present in this particular variant. But again, important, that's not the goal of vaccination. It's a good to have. It's about protecting against severe disease. And breakthrough infections occurring in people that are vaccinated will be less likely to progress to severe disease, end up in hospital or die. In addition to which, there's also evidence to indicate that breakthrough infections in vaccinated individuals are less likely to develop long COVID, the symptoms that persist for 4, 5, 6 weeks and even longer. So when it comes to severe disease, I think in that particular regard, South Africa is not only dependent on the vaccine-induced immunity. Another important feature in South Africa is that over the course of the first 3 waves, we've had between 65 to 80% of the population that have already been infected with the virus. And that past infection, fortunately, might not protect too well against reinfection and mild disease, especially when there's this new type of a variant that arises, as we had seen in the case with the Beta variant. But that past infection certainly does confer good levels of protection against severe disease and death. So I think the sum of those 2 things, the natural infection that has induced immunity in a vast percentage of the population, coupled with the vaccine-induced immunity, will result in a resurgence even due to the Omicron variant that is less severe than what we experienced in the last 3 waves. But that is not to say that people that have been previously infected should not get vaccinated. And I think we need to be cautious about this. Even if you've been previously infected, if you get even a single dose of any vaccine, your immune response, in fact, and the antibody concentration is even higher than someone that hasn't been previously infected that received 2 doses of the Pfizer vaccine. So these things put together basically puts us I believe, on reasonable, firm grounds that we're going to see increase in hospitalization, but probably less than what transpired during the course of any of the first 3 waves.
And I have a question here with regards to the J&J vaccine before we move on. So 2 doses of J&J is actually what we should be looking for instead of the single dose.
Absolutely.
Yeah.
I mean, J&J is still authorized as a single-dose vaccine, but the company's own studies clearly show that 2 doses are better than a single dose. And in fact, the study from South Africa, as an example, in healthcare workers, showed that a single dose of the J&J vaccine reduced hospitalization due to the Delta variant by about 62%, whereas for 2 doses of Pfizer, 2 doses of AstraZeneca, and 2 doses of Moderna, all of those vaccines, 2 doses of those vaccines reduce the risk of hospitalization by 80 to 90%. Due to from the Delta variant. So certainly 1 dose does give you protection, but we can do much better than 1 dose with a second dose to enhance the protection, including against severe disease and death with a J&J vaccine.
Now, I'm just thinking of the next 2 weeks as we wait for the stars to come through. What should we do as only South Africans over those next 2 weeks? I mean, last night, should the president have heightened lockdown restrictions at all as we wait to see the outcomes of it, or was it a bit too late?
No, absolutely not. I mean, the other lesson I think government has learned in South Africa is that lockdowns haven't actually achieved anything when it comes to reducing the number of people that are infected during the course of a wave. All that it has done, it is that it's extended the period of time over which the same number of people eventually get infected. If lockdowns had any impact on reducing the number of infections that transpired, we wouldn't have 65 to 80% of South Africans having already been infected with the virus during the course of the first 3 waves. Where lockdowns have played some role is that in the first wave, it sort of provided some breathing space to hospitals to better prepare themselves for the peak. So it sort of delayed it by about 2 to 3 weeks. And in subsequent waves, government has again used it as a blunt tool, which is not correct. And the third wave was a good example where when we went into higher levels of restriction, if you look at what happened across the country, in Gauteng, those higher levels of restriction came at a time when the hospitalization had already peaked. So it didn't have any value in terms of assisting healthcare facilities in Gauteng. And in fact, in the Eastern Cape and KwaZulu-Natal, they had a very mild third wave when it compared to the first and the second wave for other reasons, including high infections during the course of the first and second wave. So the lockdown didn't have any sort of benefit for KwaZulu-Natal, for Eastern Cape, for Gauteng. The only thing that it did is that it created greater havoc in terms of destroying the economy. So I think government's call this time around is correct. Yes, we might need to, based on regional data and what's happening in regional facilities when it comes to whether healthcare facilities are imminently under threat of being overwhelmed, we might need to consider some sort of restrictions, really to relieve the burden on healthcare facilities and not to try to prevent the spread of the virus or reduce the spread of the virus. That is not the main goal. The main goal is about assisting healthcare facilities should they become under imminent threat. And then we might need to have a much more tailored approach at the regional level or at least a provincial level when it comes to deciding on higher levels of restrictions.
What are your thoughts on vaccine mandates? We heard the president speak about government moving in that direction, and also that increase booster shots. Spoke about J&J. What we should do moving forward.
So immediately what needs to happen, like I said, all adults that have received a single dose of the J&J vaccine certainly should get another dose of either the J&J vaccine or the Pfizer vaccine. From an immune response perspective, combining the J&J vaccine followed by the Pfizer vaccine induces better immune responses than 2 doses of the J&J vaccine. But that doesn't mean 2 doses of the J&J vaccine doesn't work. If there isn't an option, certainly 2 doses of the J&J vaccine is better than just a single dose of the J&J vaccine. So I need to be clear about that. The second part is that in addition to those people that have received a single dose of the J&J vaccine, the government needs to follow WHO's advice. And the current WHO advisory is people above the age of 65, and especially above the age of 70, especially those with underlying medical conditions, as well as any other individual that is immunocompromised, or is also on treatment that suppresses the immune system, they immediately should receive an additional dose of the Pfizer vaccine if the last dose of the Pfizer vaccine was more than 4 to 5 months ago. So those categories of individuals certainly need to get a booster dose immediately and not wait until we are at the peak of the resurgence, because even though 2 doses of vaccine provides 80% protection in those individuals above the age of 65, as well as with immunosuppressive conditions, the third dose will increase that protection from 80% to 90% and above 90%. And that 10% might sound a little, but because of the higher risk of those individuals ending up in hospital, that 10% difference actually exceeds whatever benefit you would get by vaccinating individuals in the 35 to 50 year age group, as an example. So it's about tailoring our response using the resources we've got and being much more targeted in our approach as to who we vaccinate and ensure that we're vaccinating people to get the most out of vaccines. And the way to get the most out of vaccines is to have the goal of protecting against severe disease and death, and not try to pretend that we're doing good by giving children a single dose of vaccine as an example, which in fact will have nominal impact on protecting against infection, which is mainly what they actually develop, and mild disease, especially more so with the Omicron variant.
Now, the emergence of these variants of COVID-19, are we living in a world where quite regularly we'll see new ones emerge from different corners of the world? Is it still relevant to focus on where the variants actually emerge from?
Well, no, not really. We can expect ongoing evolution of the virus. We can expect further mutations. And these mutations, like I said, are random errors of the genome of the virus when it's replicating. So we can expect that to continue, including in settings where there is vaccine rollout. And in fact, in settings where there's suboptimal vaccine rollout, paradoxically, that might actually pose even a greater risk for further evolution of variants, because you're really wanting to minimize the amount of virus that is circulating. We're not going to get rid of the virus, through vaccines, but you're wanting to still minimize the amount of virus that's circulating. And the way to do that, the most sustainable way to do that without a loss to life, is through vaccination. If you depend on natural immunity, I mentioned that it does protect against severe disease and death, but it comes at a cost. And the cost that it has come at in South Africa, as an example, up to now, is that it's not 90,000 people that have died of COVID-19. It's closer to 250,000 people that have died from COVID-19. And that is because of natural infection. And we can't afford another 100,000 people to die from COVID-19 because before 90% of the population have developed immunity through natural infection, which will probably eventually transpire after the fourth and after the fifth wave.
I mean, I suppose looking at it, as everyone's worried about the current wave, there's one bright side to the latest concerns around COVID-19, and that whilst the cases have shot up in the country, our death count hasn't. How is this any different from previous waves in how it starts, or are we keeping track whether those who are vaccinated are getting infected?
Yeah, so right now we just need to appreciate that we're at an early stage of this particular resurgence, including in Gauteng. And the severe disease and death usually lags behind by about 2 to 3 weeks compared with what's happening in a community with transmission. So it's premature to say that this particular wave is going to be less severe. But at the same time, based on what I said earlier, I do expect it to be less severe. And that is because of the immunity that has already built up in a community, at least against severe disease. But whether this variant results in a major surge in hospitalization because of the multiple mutations, time will tell. But again, I'm optimistic it won't. And I think to some extent, the initial data is suggesting that the community infection rate is really, really high, whereas the hospitalization rate is sort of increasing much more modestly, which is good news. And certainly the other important feature of this is that most of the infections that have been identified to date is in a relatively young age group demographic who have not traditionally been susceptible to severe disease. And this time around, equally so, it seems that they are being infected, but not ending up in large numbers in hospital or dying of COVID-19, which means it's indirect evidence, early evidence, that the virus, this variant itself, is not necessarily more virulent, doesn't cause more severe disease than what we had experienced in the past with earlier variants.
Now, knowing that more variants are likely to emerge, do you think, I mean, maybe this is do you think that South African scientists should be a bit more cautious and gather enough data before announcing their findings? Or is this a global event that maybe requires just maturity from global politicians, I suppose?
Yeah, so I think we can be a bit more measured in the manner in which we communicate information. I think part of the issue is around the method and manner of communication and placing it in context. And we also need to be more broad-based in our consultation. And in this current era, that consultation can take place in a space of a few hours before we actually make this sort of announcements, so that everyone is actually aligned with the data. And that would avoid some scientists from making incorrect conclusions of the data and then making pronouncements which the governments end up acting on, which is to the detriment of everyone eventually. So I think a lesson from this particular experience is we certainly need to be sharing data in real time, but we need to look at what avenues and who the stakeholders are that we need to share the data with immediately, rather than making public announcements in South Africa, which is the first time when the rest of the world gets to hear of it and they aren't able to contextualize it, and they might end up making sort of premature conclusions of its relevance and then act in a very hasty manner.
I'm bringing a question from some of the audience. A Mail and Guardian subscriber, Arend asks whether you could envisage us having to have annual COVID-19 vaccinations going forward, rather like the annual flu jabs.
Yeah, so it's obviously early to say. And again, it depends what the goal of vaccination is. If you're trying to protect against infection, then you might well need to have an annual dose of vaccine, because the protection against infection seems to be largely mediated by the presence of this neutralizing antibody. And that neutralizing antibody does wane over time, especially if there isn't exposure to the virus, and consequently, you won't have adequate antibody concentration the time the next wave arrives, if that wave is sort of delayed, say 6 or 12 months later. So if you're trying to prevent infection, you may need to boost on an annual basis, but I don't think, like I've mentioned, that is not a goal of vaccination. The goal of vaccination is protecting against severe disease and death. And if you're wanting to protect against infection, you're going to need to vaccinate the entire population annually, which is not pragmatic under any case scenario, and in fact in any country for that matter, unless you're a small country with a limited number of people. So the goal of vaccination is protection against severe disease and death. And in that particular instance, the modeling data currently, and even the clinical data, shows persistence of protection beyond 9 months against severe disease and death of 80 to 90%, except in people that are immunocompromised, in whom there is waning of protection, including against severe disease and death, not that dramatic as I mentioned, but that you would want to top up. The modeling data suggests that to protect against severe disease and death, and based on what we know of immune responses, you might well need to boost every 2 to 3 years. But that would be a targeted boost at those individuals that are in categories of being at high risk of being hospitalized and dying. So a short answer would be that we probably would have certain people that would probably require a boost every 2 to 3 years. But then there is another category of individuals, and that is healthcare workers. When it comes to healthcare workers and perhaps some other frontline workers, where you're wanting to minimize the chances of them being infected, because when they do get infected, it obviously has got implications in terms of the healthcare services and the integrity of healthcare services. If your healthcare workers are outside because of they're in isolation or they're sick, as well as the possibility of healthcare workers to transmit the virus to other vulnerable people in the healthcare facilities. In the case of healthcare workers, as an example, you might want to heighten protection against infection, as well as minimize the ability to transmit the virus. So that's sort of a category of individual that we might need to think about for annual vaccination. And that is pretty much the recommendation for influenza vaccine as well. That healthcare workers, in particular, as an example, do receive a booster dose of annual dose of flu vaccine.
I know in the country we're talking about the constitutionality of vaccine mandates, but with regards to healthcare workers, do you think it's viable for them to push for them to be forced to be vaccinated, just to help manage this pandemic?
There's a difference between forcing someone and making it mandatory. And if people choose not to be vaccinated, then you can have sort of a mutual agreement in terms of parting of ways, because you need to put the interests of the safety in that particular workspace as a priority, and the safety of everyone else that comes into that facility. So it's not just about an individual choice, it's about how the individual choice actually impacts on everything else. So in any workspace in South Africa, under the occupational health safety regulations, is the CEO that takes on the responsibility for the safety of everyone that comes into that workspace, be it employees or be it visitors to that workspace. That is a responsibility of the CEO. And the CEO is meant to do whatever it takes to ensure that she fulfills that responsibility. So when we talk of mandatory vaccination, it might well need to be tailored based on the setting that you're dealing with, but it needs to be put into the context of what is the balance between allowing an individual to exercise their right not to be vaccinated, as opposed to the risk over and above a vaccinated individual that individual would pose to other individuals in that particular environment. So I think the entire concept of mandatory vaccination needs to be really contextualized as to who we're referring to in what context. And like I said, there would need to be a parting of ways if people choose not to be vaccinated, when clearly the evidence in certain settings indicates that they do pose a risk to others in that particular environment. And in the case of healthcare workers, it's posing a risk to their colleagues, to their fellow healthcare workers, it's posing a risk to our healthcare system, because when they go off on sick leave because they've been infected with the virus, which is more likely to transpire than in a vaccinated person, and when they pose a risk to other patients in that facility who might be fully vaccinated but not adequately protected because of underlying medical conditions, then I think that's a fully justified reason why a vaccination should be mandatory for healthcare workers, and the same would apply in other work environments.
I have a question for one of the viewers here. Why are scientists obsessed with herd immunity, and what does it mean exactly? This is from Tim Baker.
Well, they're probably not referring to me, because I'm certainly not obsessed with herd immunity. In fact, I think I've mentioned this in April of this year, in fact, in January of this year. That herd immunity is an aspirational goal which has long passed us by. It's never going to materialize. And what we mean by herd immunity, perhaps, just to step back, is that it's where enough people in the community have actually got immunity, not in protecting against severe disease, but protection against being infected with the virus, or if you're infected with the virus, you're unable to transmit the virus. For the Delta variant, as an example, 85% of the population would need to have that type of immunity, that they're unable to be infected with the virus, or if they are infected with the virus, they're unable to transmit the virus, and 85% of the population. There's no country in the world with the current generation of vaccines that would be able to get to that threshold and keep to that threshold without booster doses on a regular basis. So the whole notion of herd immunity, where there's almost no virus, where you're pretty much coming close to eliminating the virus from your environment, I think in this day and age, I don't think there's any scientists that would still believe that with the current tools we've got at hand, that we're ever going to get to this herd immunity threshold. It is very likely that the virus will eventually sort of become more sort of an endemic coronavirus, which circulates all the time, causes mild illness, but doesn't really materialize in severe disease. So I think that is where this virus is heading, rather than us being able to eliminate the virus.
How are you and your team monitoring when we'll see the next peak of the fourth wave, and based on modeling, how bad could it get as compared to the previous peaks?
Yeah, so it's the National Institute for Communicable Diseases, the NICD, that does most of that work, tracking what's happening across the country. And their information is quite, it's available on the NICD website. It comes out on a weekly basis, sometimes on a daily basis, where they provide an update. And that's really useful information. And then the modelers look at the same data and try to project as to predict what is going to happen. But right now, what's different from this wave compared to what we experienced in the earlier waves, as I mentioned, is a much greater percentage of the population have developed immunity, at least against severe disease, from both natural infection as well as vaccine-induced immunity. How well it performs against the Omicron variant, unknown, in protecting against severe disease. So I think the modelers would have different scenarios, and the estimates would be probably anything between 20,000 to 100,000 people, as an example, which is really a wide confidence, a wide interval, a wide range that could possibly die with this particular resurgence. And the reason for that is the real uncertainty about to what extent this immunity that has already evolved in the community would protect against severe disease and death. But in the next 2 to 3 weeks, I think we'll be much more informed as to how the sparse infection and vaccine-induced immunity is protecting against severe disease due to the Omicron variant.
Whilst we wait for those next over those next 2 weeks, in closing, Professor, I want to get a sense for you. What are the key focus areas right now for the country as we carry on with this war against this pandemic, and I guess globally as well? What are the key areas to focus on if we want to get past this phase?
Yeah, the first and foremost, and we keep on harping on the same issue, is that vaccines are the most sustainable manner to actually get us to a stage where we can learn to live with the virus. So everyone needs to be fully vaccinated. People that have not received any vaccines, certainly one dose is better than none. And in fact, for the majority of South Africans, 2/3 of who've already been infected with the virus, knowingly or unknowingly, that single dose of vaccine would confer really good protection, not only against severe disease, but also against infection and mild COVID. So getting that first dose of vaccine into the arms of people is absolutely essential as quickly as possible. But in addition to that, it's obviously what I also mentioned, the need to prioritize those groups where we haven't been able to get 90% coverage, and that is people above the age of 50 in particular, and people with underlying immunosuppressive conditions. And like I mentioned, to provide that additional boost in those high-risk groups. Beyond that, it's about in the immediate future, I think what we need to be cautious about is avoiding mass indoor gatherings, especially in poorly ventilated spaces. What we've come to understand of the virus over the course of the past 3 waves is that 80% of infections are either directly or indirectly related to indoor super spreader events. So we know what causes rapid dissemination of the virus. It's not about preventing infections, but it's trying to avoid rapid spread of the virus, which eventually materializes in healthcare facilities coming under threat. So avoid indoor gatherings in poorly ventilated spaces especially, and wear that face mask when indoors. Enjoy the outdoors. You really don't need to be wearing a face mask when you're taking a jog and when you're walking on a beach. The chances of being infected to the virus is pretty much zero under those sort of settings. Is when you're going to the shopping malls and when you're in the restaurant indoors, unfortunately, that is when you're actually at risk of being infected with the virus.
Right. Professor, thank you so much for joining us, and hopefully we get a chance to speak to you in a couple of weeks' time when we have more data and we have a more clearer sense of what this variant is about. But thank you so much for joining us this evening.
Okay, great. Thanks a lot.
All right, that was Professor Madhi, and this is Ron Derby, the Editor-in-Chief of the Mail and Guardian. Thank you so much for joining us. Mm.